Okay, let's begin. Hi, everyone. For those of you who don't know me, my name is Derek Noland. I'm a community liaison here at the Behavioral Health and Wellness Program. As you can see, we're based at the University of Colorado School of Medicine on the Anschutz Medical Campus. And the funding for these webinars and a lot of the work that I do is through the Tobacco Innovative Grant that the Colorado Department of Public Health and Environment coordinates with us on. And so I'm happy to bring you these webinars. This is the first one this year, and I'll be looking to do 3 more over the coming months. So please do stay tuned for more news about those. So for today's topic, we're going to look at treating tobacco dependence, and we'll be focusing on that within the realm of co-occurring behavioral health and substance abuse conditions. So that will be our focus. I'm going to move through the material at a pretty good clip because I have a lot that I'd like to cover. There will be an opportunity to contact me after the webinar. My contact information will appear at the end of this presentation. And if you have any follow-up questions, I definitely encourage you to please reach out, and I'll be happy to answer those for you. Okay, let's begin. So today, here are our objectives. Upon completing the training, we'd like participants to be able to understand the burden of tobacco dependence upon people with behavioral health conditions. We'll explain some of the concepts of addiction and commonalities in treatment across different types of addictions. And we'll learn some treatment strategies and best practices for helping people with co-occurring behavioral health and substance abuse conditions. So let's begin by looking at that, the burden of tobacco and substance abuse. And again, with that focus on behavioral health populations, which will become apparent the reason why we're focusing there. So more broadly, the burden of tobacco across the United States, we're looking at nearly 500,000 deaths every year. That number may be even a little higher as we continue to learn about different types of diseases that tobacco is associated with. That number will only rise in all likelihood. We also know that there are about 6 million tobacco-related deaths worldwide each year. Another way of looking at that, as you can see, is that we estimate that there is a death from a tobacco-related illness every 6 seconds. So clearly this is a major burden that is by no means going away or gone at this point. It's also important to note that there's 16 million people in the United States living with tobacco-related chronic illnesses. So even if people aren't dying of tobacco, it is nevertheless impacting the quality of life. All the different healthcare considerations. Their ability to contribute to society and do things that they enjoy and so forth. We also see 42,000 deaths each year in the United States due to secondhand smoke exposure, so that remains a concern as well. Looking more closely at behavioral causes of death in the US, so these are conditions or causes of death, I should say, that we in most cases do have some control over. You can see that tobacco far outweighs all the other common behavioral causes of death on the right bar combined. And I want to draw your attention to the line in the asterisk that's running through the tobacco chart, because that number represents the number of tobacco deaths that are associated to people with behavioral health or substance abuse conditions. And as you can see, that is a very high proportion of our overall deaths, roughly about 40%. So that really at its crux is the reason why we spend so much time focusing on this particular group. Another way of looking at this is that people with behavioral health conditions are on average nicotine dependent at rates 2 to 3 times higher. So they are obviously in this case consuming more cigarettes or other tobacco products. And along with that 40%-ish figure that we saw on the previous slide, you can see that these populations do consume about 40% of all cigarettes smoked and represent about 44% of the US tobacco market. And obviously the tobacco companies are well aware of this fact and do strategically target these populations. We also know that tobacco use does affect mental health care and treatment. So in a negative way in this case, So people with behavioral health conditions that are using tobacco actually do have more psychiatric symptoms due to their tobacco use and ramifications from that. They also experience increased hospitalizations and similarly are more likely to leave against the advice of their doctors, particularly when withdrawal symptoms are not treated. And we will look at those briefly as we go through. It's also important to point out that people would typically require higher dosages of medications, and with that come a lot of very serious side effects and obviously just cost of the medicine as well. So I want to look at a few pertinent types of addictions or substance abuse conditions here. Want to quickly acknowledge e-cigarettes or electronic nicotine delivery systems as well. So a little bit of background information about e-cigarettes. Obviously, this is a quickly growing field. Rates are going up very fast, and especially over the past few years. Unfortunately, youth usage of e-cigarettes is a particular concern, as those rates are going up very fast. Note that e-cigarettes are not an FDA-approved cessation device at this time. Perhaps way down the road with further testing, there will be some form of that, but that's unknown at this time. Due to the, again, unknown health risks that are associated with e-cigarettes, they are by no means emissions-free. They do contain harmful chemicals, and the real bottom line there is that we don't have any long-term studies on this topic. And moreover, they don't address addiction to nicotine or the pattern or habits of smoking. Rather, they actually enforce or reinforce nicotine dependency. So that's a little information about them. To look specifically at young users, you can see that that right slice of the pie are people in the 18 to 24 category who are currently using both e-cigarettes and cigarettes, and that is a big part of why we're so concerned about them as well. This sort of dual usage is a real long-term concern. So a few others I'll go through. Opioids are obviously a very pressing concern right now as this public health crisis continues. You can see here the note on this slide. Opioid pain relievers are the most prescribed class of medication in the United States, with upwards of 300 million prescriptions written each year. And we are working to combat that, but we still have a lot of progress to make. And this has obviously had a big impact. This overprescription of pain relievers has led to an escalation of misuse and abuse. At the same time, if people do become dependent to the substances, it has led to a resurgence of heroin use in recent years. And you can see there that the drug overdose deaths associated with this are very high. And then this number has even grown a little more in recent years. And you can see that of the drug overdose deaths, about 60% were the result of opioid use. So clearly, very important topic. Alcohol should not be overlooked as well, even if it is legal and use is prevalent. You can see a lot of stats here about just how prevalent that use is. Over a third of Americans aged 12 or older report current use. About a sixth or so, or fifth or so, reporting binge alcohol use just in the past month. Many people also reporting heavy alcohol use, and want to also acknowledge that there is a large, economic impact of this use. So don't want to not mention alcohol use. Obviously, marijuana is another very important substance that's being more and more used and growing in usage. As you can see, this is as of 2017 state marijuana laws, where the light green states have legalized recreational use in the dark with medicinal, and this is actually growing. This map has already changed since it's been produced, so this is something that we need to stay on top of. As a result, we're seeing a lot more youth marijuana use. We're seeing a significant decrease in the mean age of first marijuana use, and with these changes, there's among young people in particular, there's a lack of perception of the harmfulness. There's a lower disapproval of use generally. And important to note that marijuana smoke does have carcinogens in it. We still have a lot to learn about long-term use, and that research will be coming, but we're still in the infancy of that. So a lot to learn, but obviously we want to preach a safer approach. So those are some ones that I wanted to call out, and now I want to look at the concept of addiction a little more broadly. Kind of the underlying commonalities that exist across different addictions. So why is this important? Well, on average, people diagnosed with mental illnesses and addictions have higher rates of disease and disability, and may even die up to 25 years earlier than the general population. So the more we're able to help people avoid addictions and things that are within some control, the better lives that they will have and longer lives. So this is kind of the theme throughout, that addictions do have commonalities, and therefore we can take common approaches in treating them, and being strategic in doing so can certainly help to maximize our efficiency and our ability to treat people. Similarly, a lot of addictions do follow this dopamine reward pathway, which we've sort of generally mapped out here. Nicotine in particular through cigarettes is particularly efficient at doing this. When someone puffs a cigarette, within 10 seconds, that nicotine has entered the brain and triggered that dopamine release. And the quickness in which that occurs really helps to underscore and reinforce dependence when there is that immediate association. And other drugs also mimic this pathway, like opiates and so forth. And it's a very strong pathway. It's associated with other basic human survival mechanisms like hunger and sex and so forth. So when drugs do mimic this, they can be very powerful. So we're not going to go into detail here about some of the neurochemical effects of nicotine, but what I do want to point out is that it can be used to meet a variety of different purposes. You can see here for pleasure, for concentration, reducing anxiety, appetite suppression, a lot of different ways in which people use nicotine based on how they smoke cigarettes and when and so forth. And I just want to point this out because it is important in that it can help to reinforce that addiction across a number of different mechanisms. So good to know when you're working with people what they often pursue when they are smoking, and can kind of strategize around that. So here is a kind of general mapping of the nicotine addiction cycle, and this looks similar for all the different substances that we're talking about today. So you can see the tobacco product or substance is used at the top of the cycle there. We absorb the nicotine or drug and we get that dopamine release, which will provide whatever effect the person might be looking for, whether it be arousal, pleasure, mood modulation, etc. Over time, tolerance and physical dependence develops. When those are not, when the physical dependence is not met, we then encounter withdrawal symptoms, which lead to craving and use of the product, and on goes the cycle, potentially strengthening over extended use. So it is a problematic pattern of tobacco use that leads to clinically significant impairment, as you can see in that definition there on the left. And I also want to point out that addictions can form in a lot of different ways, but there's a lot of crossover among populations that do become addicted to a substance. And what I mean is that a lot of these pathways on the left, you will see more than one appearing in an individual. So really any sort of stress kind of is an underlying commonality here. stigma against product use, being of a lower SES background, discrimination, a lot of different things that can lead to addiction, including the person's biology, their ability to get treatment, exposure from their environment, whether that be at work or with friends or family or what have you. Obviously, tobacco industry targeting is something worth noting again here. And really, there's a lot of different ways that someone may become addicted to a substance over time. So it's important to have this in mind as we're looking at that. There is a gap between our understanding of this and the services that are being offered. And so that's part of what we're seeking to address with our work here at the Behavioral Health and Wellness Program. We want to minimize this science to service gap as best we can, because as you can see, the different statistics here, that there just isn't enough access to these sorts of treatment in different facilities as there should be, particularly in mental health care and substance use treatment settings. And the bottom line really is that first point, that 1 in 3 adults who have co-occurring serious mental illnesses and substance use disorders are not receiving either type of care. So really a big disservice here that we're working to try to mitigate. So let's switch gears a little bit, and now we're going to look at tobacco dependence amid behavioral health conditions and addictions. So I'm going to keep it specific to tobacco for this section, but there are some commonalities here in the other addictions as well. So these are all considerations that you would want to keep in mind when helping to treat someone for tobacco dependence. Okay, so we know that tobacco use affects treatment and recovery from addiction, and typically in a negative way. People who are alcohol dependent, for example, are 3 times more likely to use tobacco. So that's just another example of dual use that we see. And so in that instance, you would want to treat both the alcohol dependency and the tobacco use, for example, to maximize the likelihood of success and abstinence. You can also see that second point there, that tobacco use is a strong predictor in the use of illegal substances like methamphetamines, cocaine, and opiates. And this all leads me to that final point. I've highlighted that 25% increase as it's so critical to this concept. So addressing tobacco dependence during treatment for other substances, whatever they may be, is associated with a 25% increase in long-term abstinence rates from alcohol and other substances. So I really want to highlight that point. It does go against some of the misnomers that still exist in this industry where, if someone's dealing with a challenging addiction to a drug of some sort, they might, the counselor or treatment facility might recommend that they still be able to smoke because that's perceived as the lesser of the evils. But the reality is, and the statistics back this up, that quitting all of the substances at the same time is going to be more successful in the long term. And sure, there's variation between people, but 25% increase in success is a big deal, and we don't want to overlook that. So want to turn to concurrent use with other substance abuse treatment, with tobacco in mind here again. So 75% of clients believe tobacco treatment should be offered while in treatment for other addictions. So clearly there is popular support for this. People typically do want to quit, and that's expressed there. You can see another way of looking at this is at discharge. About half smokers thought that a tobacco-free policy helped them address their tobacco use. We wholeheartedly recommend tobacco-free policies. They are effective, and usually they're much easier to manage and enforce than would be perceived. Also, this important to note that this does not cause people to experience worsening psychiatric symptoms, so we don't really have to worry about that aspect. Okay, so cessation concurrent with psychiatric treatment. Smoking cessation has no negative impact on psychiatric symptoms. Moreover, smoking cessation generally leads to better mental health and overall functioning. So again, we're combating that notion of allowing people to continue smoking when trying to treat other mental illnesses or addictions. It simply is not as effective as quitting at the same time, and that's really what that slide is highlighting again. So on the other hand, psychiatric symptoms are not exacerbated by smoking cessation, so there isn't a backside to this or a backlash against this. Smoking cessation is associated with actually decreases in levels of depression, anxiety, and stress. You also often hear that people smoke to reduce their stress, but that is more of a short-term fix, and in the long term, that stress would only increase due to that use. We also know that smoking cessation is associated with an increase in positive mood, and of course, the quality of life compared with continuing to smoke is less exposure to diseases and all the harmful substances and cigarettes. The effect size seems as large for those with psychiatric disorders as those without. So it is consistent there, and the effect sizes are equal or larger than those of antidepressant treatment for mood and anxiety disorders. So we can actually get the most bang for our buck by highlighting and aiding people in smoking cessation. So that's really important to consider as we're doing this type of work. Okay, so now let's turn again and look at tobacco and substance use withdrawal and relapse. So I want to spend just a little bit of time on this as it is an important consideration. We want people to be able to focus on their behaviors, and I will address that again later. But clearly we need to treat withdrawal symptoms and be prepared for relapse in order to have our highest chances of succeeding and aiding that person in a quit attempt. So in doing this work, we want to identify high-risk situations that might lead someone to choose to smoke a cigarette or to engage in another drug use. So there are specific behaviors, emotions, environments, and people too that may act as triggers. So all sorts of different things in play here, and we've listed some common ones there. Being in a negative emotional state may lead someone to smoke a cigarette or engage in drug use. And it's also important to know that positive emotional states can too. Being in a celebratory mood for some people would lead them to pursue that substance. Interpersonal conflicts are a big one, and that may tie into people being triggers. If someone is working through quitting substances, there may be people that they need to avoid for that period of time or even longer if it is a serious problem in maintaining their quit attempt. There's a lot of social pressure that we would want to be aware of if their social networks smoke, for example. Obviously, urges and cravings, that last point, kind of our biological piece, not to be ignored by any means. Need to recognize that those do exist. And that's what we are focusing on with this slide, nicotine withdrawal effects. And so it's really important to know how nicotine withdrawal unfolds in the individual. And there is variation based on the person and their metabolism and their level of dependence and biological factors and so forth. But generally speaking, most withdrawal symptoms do they do start to decrease relatively quickly. So you can see there that they start to appear within the first day or two, starting to get more intense and then peaking around the first week. But then they start to decrease over the next 2 to 4 weeks. And again, that varies widely. But if someone is able to make it through that first week, they have beaten the peak of those physical withdrawal symptoms, and true to the point, if they've made it through about a month, you can essentially say that they are free of the withdrawal symptoms. Now, that does not mean that the behavioral aspects of their substance use have been, or nicotine use in this case, have been addressed, but we have made it through the most challenging physical part. So here are some common withdrawal symptoms that you can look for. Irritability, frustration, and anger are all very common things that we see as people are dealing with the unpleasant aspect of withdrawal symptoms. They're not enjoyable, obviously, and so those are ways that people manifest their emotions. You can also see anxiety, restlessness, impatience, depression. So a lot of different mental health factors that come into play with withdrawal symptoms, and it can look really different depending on the person, as you can see there. Difficulty concentrating can be a real problem if a person has used cigarettes, to focus in certain situations. Also, insomnia can be a real factor. If they're having trouble sleeping, that can only make it more challenging to quit. And an increased appetite is also a common withdrawal symptom, and we do tend to see some weight gain, and that's even more common in women. And it's important to highlight that this isn't drastic. It would only be a few pounds, so we always encourage people to focus on the benefits of quitting smoking, greatly outweighing any risk associated with just gaining a few pounds. Obviously, it's not something to minimize because it's important to people, obviously, but the bigger picture is that it's better, obviously, to quit smoking. So that's an overview of withdrawal effects, and obviously the way that we can best address those is with a medication. And so that ties into, why would you use a medication for quitting, in this case, tobacco? And obviously the bottom line is that they do make people more comfortable. They reduce those withdrawal symptoms that we've highlighted, which can be very challenging. Also, they allow people to focus on changing their behavior. When their physical dependency is met, they can then turn their attention to work on replacing behaviors and building new healthy behaviors. And as we'll see in an upcoming slide, the bottom line is that medication does statistically improve chances of a successful quit attempt. And often that improvement is pretty large, depending on the medicine and how it's applied. So here are the 7 FDA-approved tobacco cessation medications. I'll just kind of do an overview of these. So the first 3 on the left there, nicotine gum, lozenge, and patch, those are all available over the counter and come in a variety of different strengths so that the person can really cater their usage to their level of dependence and any sort of considerations they might have in way of, skin irritation with the patch or dental complications with the gum, for example. All 3 of those over the counter, different strengths, and can be used in combination to try to get the best result. The nicotine nasal spray and nicotine inhaler both are available by prescription. They are more expensive than the first 3 and a little more, they're definitely less common. So they do exist, but the first 3 you're more likely to see. And so all 5 of those do contain nicotine. And so essentially they are NRT, nicotine replacement therapy, and that they are introducing nicotine to the body that the person would otherwise be receiving through cigarettes. And so they are safe to use. It's a safe form of nicotine, with the exception being in pregnancy. And then we have 2 other types there on the bottom right. We have our bupropion or Zyban tablets and varenicline or Chantix tablets. And so these are psychoactive medications that a person can get only by prescription. And also Zyban can be used with some of the first 3 NRT in combination. So really one of the key things here is to try to match the medication to the person's not only dependency, but preferences and priorities, and really try to find the best combination of tools for that person. We also find that people are often underprescribed medications, so the more information we're able to get about a person's tobacco use history and level of dependence, the better we can really craft this medication to be sufficient to meet their needs. Okay, also want to acknowledge that relapse does occur, and I want to distinguish that a lapse is an isolated use of tobacco or substance, so, you know, having one or two cigarettes, versus a relapse where the person returns to sustained use. Obviously, relapse can be a challenge, and with different substances, and especially with tobacco, it can take many times to successfully quit. So while we don't want to set up the expectation that someone will relapse, we do want to let them know that it's a very common thing, and point out that people may need to practice in order to be successful quitting, and even more importantly, that there's a lot of valuable lessons that can be learned from past quit attempts that can really help to build an understanding of what will work for that person and what won't. And so there's a lot that they can learn there. With that in mind, here are some basic relapse prevention strategies. So these are some methods that exist for minimizing the risk of relapse. Both with tobacco and substance abuse, we want to avoid usage. That's fairly obvious, but particularly in the first 2 weeks of a tobacco quit attempt, we know statistically that any sort of use during that time period would be all the more likely that someone could relapse and begin to use regularly again. So, and obviously, if we're working to quit, we want to not use these products, and that's all the more important in the beginning. Also important is to identify and plan for high-risk situations. So being thoughtful and being considerate of that person's individual risk factors. If there's someone, say, in their family or social network that they smoke with, and you can anticipate that that person will at some point ask them to join for a smoke, we should think through that situation and be prepared for how they're going to react, what they will say, be very specific. We definitely want to very carefully plan for these type of high-risk situations. You know, if it's associated with certain behaviors like driving a car or having coffee or alcohol or what have you, we want to think through those situations and try to figure out ways that we can limit that risk. Another important point is to enhance self-efficacy through supportive relationships and behaviors that support well-being. So basically empowering that person to trust and believe in themselves, to get them to identify the tools and supports that are going to help them as they continue with their quit attempt and to avoid relapse. So, you know, get them talking about what has worked in the past, and who they think they can rely on, for example. And this has been something I've been stressing throughout the webinar today, but we do want to quit all substances simultaneously, and that will lessen the risk of relapse for any one of them or all of them collectively. Okay, so that's that section. Now I want to look a little more comprehensively at this point at treating substance abuse. So these are some overarching themes and concepts and so forth that want to introduce with the concept of treating all these substances collectively. And then after this section, we'll start to look at some more broad and then even more specific strategies. Okay, so because of all these common underpinnings across different substances and addictions, we know that co-treatment is the best and really the only adequate solution here. The biopsychosocial underpinnings are similar for the different substances. So that would be biological factors, the person's chemical makeup, their social networks and social structures, their psychological dependency on substances. All of these factors are similar across substances, so things that may drive tobacco use will be similar to things that would drive marijuana use or opiate use or what have you. So when we're working with people, important to recognize that. We also know that this is not related to age, sex, race, ethnicity, gender, culture, etc. So these sort of treatment models, or this concept of treating all these conditions simultaneously is valid regardless of the person's demographic characteristics. So good to know as we go through this. And I've already talked about this some, but I'm going to give it a little more due diligence here. Substance abuse has two key parts, and this is whether we're talking about tobacco or another drug. But it really is a two-part problem. We have our physical dependence to the substance, so the biological dependency and the withdrawal symptoms that would be associated with abstinence from use. That's one half, if you will, of this problem. And in some ways, this, again, half is can be easier to treat, at least as tobacco is concerned, and that we can really provide people with the same level of nicotine through our NRT substances. And then the second part would be the behavior or habit of using the substance, which is equally important. We know there, that last point, that treatment should address both the addiction and the habit. It's absolutely critical that we think through both these things as we're going through, because if one is neglected, it ultimately is more likely to lead to return to use. I think a great example of this came out of a training that I was a part of last week, where we're implementing tobacco cessation programming into jail settings where people are unable to smoke when they're in that setting, and sometimes they may be in there for a month or so. And so during that time, the physical dependence of the substance, it will essentially dissipate or disappear, because as we know, those withdrawal symptoms can pretty much clear out after 2 to 4 weeks. However, many of those people do return to smoking immediately after leaving jail, even though that physical dependence is eliminated, because they have not addressed or considered the behavior or habit of using substance. So it's kind of a difference between stopping smoking and quitting smoking is the way that we frame it. So just a good example of how important it is to address both of these elements. Similarly, at the Behavioral Health and Wellness Program, we really believe in a whole health approach, not just treating a certain aspect of an individual's life or addiction, but thinking coherently and cohesively about all the things that make up a healthy and happy person. And so thinking about this in another context, we really believe that integration is the new norm. Because of this whole health approach and the way in which different people like different types of services and treatments and so forth, we really think that we need to be working across a variety of healthcare sectors. You can see there's a few common ones identified there. We have public health and Quitlines and integrated care, health homes, and so forth. But really integrating is key. Integrating on the community level, having different chronic care services, having preventive care services, being conscientious of diagnoses and codes and EHR measures that we're able to receive payment and to receive payment for the services that we provide. But that kind of ties into this next slide. We're really trying to shift the way in which we're looking at meeting patient needs. And this is particularly important in the terms of tobacco. So you can see this is the patient-centered medical neighborhood, and it's an innovative service model that we have. And you can see that any point of service can become the hub of care. So as opposed to the more traditional model where you have a a physician practice in most cases, and individuals need to come to that. We're trying to flip that around so that it's a much more person, patient-centered model where that person can get access to healthcare at any number of different settings. And you can see in this diagram here, we've highlighted a few of the common ones, whether it's the judicial system at pharmacies, local public health agencies, primary care settings, substance abuse treatment settings, et cetera, et cetera. We really want that person to be able to reach the services that work for them, whether, in terms of what they're comfortable with, in terms of cost, in terms of, especially in rural settings, in terms of convenience and proximity. So really trying to make it as easy as possible for people to get service at the most convenient setting for them. Thinking through the patient's eyes and not so much the provider's. And what other benefit do we see with community treatment settings? Well, there's a lot. This model does introduce more expertise in behavioral change. A lot of these treatment settings are really specialized, and we can benefit from that. Having alliances and therapies among different settings can really help to reinforce and sustain quit attempts. Co-occurring treatments so that we're conscious of all the different considerations and medications being provided, so that's all coordinated. It gives us more access to high-risk populations that may not be going to primary care settings. It's obviously patient-directed, and that the patient can choose which environment works best for them. And it complements other prevention and wellness activities. And really the bottom line is that it does offer the best continuity of care when we're able to have these services available so broadly. Okay, so as promised, now we're going to talk about some actual specific strategies and best practices. And so for this section, I'm going to look at treating substance abuse more broadly and strategies that sort of overlap all the different substances that we're talking about today. And then we'll look at tobacco more specifically. So counseling and support, great place to start with all different substances. People are more likely to be successful in stopping tobacco or substance use if they do get help through counseling and social support, if they prepare and plan for their quit attempt. So, being more engaged and self-directing in their quit attempt is very powerful. Obviously, we've talked about this. If they change their behaviors related to their tobacco and substance use, they're more likely to be successful. So that ties into what we've talked about, identifying triggers and risks and so forth, and being conscious and planning ahead. So, just a really strategic, thoughtful approach aided by counseling and support really is critical. And there's a lot of different behavior change interventions that are available to us. I won't go through all of these in any detail, but you can see CBT is a common one. Just straightforward clinician advice to quit can be useful. Individual counseling, as well as psychoeducational groups or group counseling, is another option. Peer support interventions, and making sure that materials are tailored to the specific people that we're working with. We'll look at a couple of these a little more closely as we go. Some broad behavioral strategies that we can use. We've talked about, we mentioned CBT, also contingency management, using motivational enhancement or motivational interviewing techniques is another really common one. And these sort of strategies could be telephonically based, obviously in person as well. School-based models are becoming more common and effective. I know Colorado's making some steps in that regard. So implementing these strategies is important too, in addition to what they are. Self-management support, another broad strategy, and that is providing patient-centered care that really engages and empowers the patient to kind of self-direct their quit attempt. And so obviously, if the patient is at the center of this support, it will be responsive to their specific preferences and needs and values, and therefore will be more likely to succeed. To empower patients, we want to provide them with all the different tools and resources for their self-care that they could utilize and benefit from. We want to offer education, whether it be, spoken or pamphlets or what have you, offer skills training, so giving them practical ways to work on a quit attempt. We want to identify community resources and refer them to those for support. And then the follow-up piece is important too, staying in touch, staying connected, and continuing to be a resource. We've talked about medication. Obviously, medication-assisted treatment is important regardless of the different substance. You can see a combination of behavioral interventions and medications to treat substance use disorders. That's what we're talking about here. It's effective treatment for individuals with all different types of dependencies, alcohol, opioids, tobacco, etc. And as we're looking more at this, the illegal drug use, it does reduce the illicit drug use and overdose deaths as well. So another broad strategy would be motivational intervention or interviewing, as we'll see on the next slide. And broadly, motivational interviewing is a guided conversation technique where we encourage and guide our clients through identifying their own strengths and building their own motivation for wanting to do a quit attempt. At the Behavioral Health and Wellness program, we do use a motivational intervention, which is distinct in that it's a 30-minute semi-structured interview. So more of a tailored intervention here. It's something that we can use to increase people's readiness. If we're running a tobacco-free group, it could also screen them for appropriateness for the group. So, thinking through developing tools like this can be a really good strategy. Obviously, training people in motivational interviewing can be really important too, so that they're able to do even a more broad, a broader approach than just the motivational intervention. So motivational interviewing, for those of you who do not know, it's kind of a 4-part strategy where we engage the client, so we get them talking about what it is that they're interested in discussing, and try to guide that to the substance or substance of focus. So that is kind of the focusing piece, getting more specific and looking at behaviors they might want to change, evoking their own strengths for how they can do that, and then taking it through and planning. And at the Behavioral Health and Wellness program, we do offer motivational interviewing training. We have a level 2 training coming up this summer, so if you're interested in more about that, please visit our website there. Peer models are also really effective, and if you're not familiar with this, a peer provider is a person who uses his or her lived experience of recovery from mental illness and or addiction and learns skills and formal trainings to deliver services in behavioral health settings to promote mind-body recovery and resiliency. So I've done this type of work with peers who have a history of being homeless in the past, and they've been extremely effective in helping people who are currently at risk of homelessness and navigating and getting services that they need. So I really believe in this and vouch wholeheartedly for it. If you'd like more information, you can see at that link at the bottom on our website, bhwellness.org. We have toolkits available free for download. We do have one specific to peer support programming, so I encourage you to check that out if you're interested. Okay, so let's look at treating substance abuse with specific tobacco strategies in mind now. We do know that tobacco dependence treatment does not need to be in a silo, so I want to kind of put that out there at the onset, that we want to do this, across the board and decrease the stigma associated with it. So here's a quick overview of what we know works statistically: increasing the price of cigarettes, media campaigns, insurance coverage, obviously, so that we can fund service provision. And then there's, in the green boxes, some more even specific tobacco strategies that work, and we'll kind of look through these as we go. But Quitlines and web and mobile-based interventions, tobacco-free policies, psychosocial treatment, and of course our medications. So tobacco groups and Quitlines are a really big piece of this. The Behavioral Health and Wellness Program does have a tobacco-free group that we believe in that uses a flexible model. We will be having a training in that this summer. That will be, or actually this fall probably, that will be open, and we'll teach people about tobacco fundamentals and how to run our group. But there are other group models as well, so these are effective strategies. Another common intervention is the 5 A's. So our ask, advise, assess, assist, and arrange around tobacco use. So asking someone about their tobacco use history, advising them to quit tobacco, assessing their level of dependence, assisting with helping to navigate a quit attempt, and arranging for follow-up and further services. So don't have time to get into more detail, but it's something that definitely works in tobacco, and the more broadly we're able to implement this, the better. A carbon monoxide monitor, or the stethoscope of smoking cessation, could be another useful tool. Essentially, this monitors the level of carbon monoxide in a person's blood, and so you can see their body cleansing itself over a short period of time. It's non-invasive, it's a visual motivational tool, so people can actually see their measures and start to learn about the severity of their dependency as well. So I've mentioned tobacco-free policies a few times. If you would like more information on that, again, we do have a free toolkit on tobacco-free policies, so I would encourage you to look at that. But that's another effective strategy in tobacco treatment. Here's another slide I'd like to include. It's kind of a heat map, and so this is a way that you can look at your health systems improvement or redesign, and this is just one way of doing that. But really mapping progress can be helpful to give a snapshot of how an organization is doing. So this was for our Build a Clinic project that we ran over the last couple of years. You can see on the left model, this is at onset. The organization was running, the organization scored itself across a variety of different tobacco services that it was offering. And with the darker, the shade of red indicating more success or a more robust offering in that particular field. And then we can compare that to the right, where after our intervention, the organization was offering much more comprehensive and robust services. So this type of tool is a great way to get a snapshot of your organization's success. It can be hard to articulate it otherwise. Registries are important, so asking and screening for people about tobacco use and having that built in and automated is a great way that we can stay on top of this at every patient encounter. And the bottom line about our cessation interventions is that they do work. So you can see here, these are abstinence rates from cigarette use at 6 months out from a quit attempt. The unaided format, which is just kind of your cold turkey quit attempt, we usually see success rates around 5%. So that's much lower than any of the other things that we can do. The self-help approach, where we're empowering and guiding that patient, can get to the low teens, whereas individual and group counseling can both get to the high teens. You can see medication is very important. Medication alone, we can get 20 to 25%, depending on the type of medication and so forth. And then the gold standard really is combining medication with counseling and these other approaches. And that's where we can really start to see the biggest success rates. Okay, so just a few more slides here. We're going to look at a few specific tobacco cessation resources that anyone can look into right away if you are looking for specific tools. And obviously, you can follow up with me afterward for more information on anything that you see here. But tobacco-free groups, again, this is a big component. Generally groups have a weekly drop-in function, and we believe that participants can join at any time. I'll call attention to the Jefferson Center for Mental Health, which is currently running our Dimensions Tobacco-Free group. And if you are interested in learning how to run groups yourself, I'll note again that we are going to offer that training in fall. So if you're interested, please let me know and I can provide you with more details. Tobacco-free Quitlines are really important. So our Colorado Quitline, you can see the number there, 1-800-QUIT-NOW, and it offers a whole host of services. A lot of free coaching and free medication that's there to take advantage of. So we definitely recommend that you refer people to that resource as appropriate. They have telephonic, online, and fax enrollment. So a lot of different ways that someone can get involved. We do encourage warm handoffs when appropriate. Not everyone may have a phone or may feel confident or comfortable calling the line. So you could certainly call with them and help get them set up. You can see the website there, www.coquitline.org. That's the Colorado specific one with more information to help people get set up. Also, there is a Colorado Quit mobile app. You can see this is free to download. You can go to www.thisisquitting.com. It can be personalized. It also offers phone-based support and counseling, which is really effective, especially for youth populations who are potentially more likely to be engaged through that mechanism, through their phones than otherwise. I also want to mention the Colorado Tobacco-Free website. This is something that we're CDPHE and the Behavioral Health and Wellness Program are really excited about this. CDPHE has done a lot of work to really make this website as modern and as thoughtful as possible. You can see that middle point's really important. It's designed to serve all types of smokers and match their readiness to quit. So include smokers who aren't quite ready to quit but are thinking about it. And that's a really big expansion of services and philosophy. So there's really something there for everyone. So we encourage you to direct people to that. The website, as you can see, will be launching very soon in April. You can see the website link at the bottom there, www.tobaccofreeco.org. There is going to be a Spanish language version. For those of you who have our technical assistance grantee funding, you have access to that behind the scenes version so you can get a feel for it. Obviously, it has a lot of facts, tips, laws, applications, resources, etc. So a lot more information there. Please check it out. And one final resource I want to note is that the Behavioral Health and Wellness Program does run a Rocky Mountain Tobacco Treatment Specialist training program 2 times per year. We actually have one coming up in the middle of May, and we do have spots available. So if you're interested, please do reach out to me. Essentially, this program is designed to empower people to ultimately become certified tobacco treatment specialists, which is a designation for which you can bill and get paid for your services. Our training builds on your existing knowledges and skills, and we share a whole lot of information, a lot more than we could possibly cover in webinars, about how to effectively implement evidence-based tobacco cessation strategies. And you can see we cover all 4 of these core TTS elements. And also want to point out that we are partners with the National Behavioral Health Network, and they have more information too that you could certainly review. So here's my contact information. Again, this is Derek Nolan with the Behavioral Health and Wellness Program. I thank you all for attending. I definitely encourage you to please reach out to me if you have any follow-up questions or thoughts. You can see my phone number there, 303-724-3714. You can also email me, derek.noland@ucdenver.edu. And again, I definitely recommend that you check out our website, bhwellness.org. And on that website, of course, you can find all those free toolkits I mentioned to download, and also more information about our upcoming trainings and programs. And with that, I thank you all for your interest today. And we will have another webinar at the end of April, which I will be sending a formal announcement out about next week, and intend to focus on e-cigarettes for that one. So it should be a really pertinent topic, and I hope to see you then. All right, thank you.